We're talking all things peptides today. Thank you so much for joining me, Kyle Gillett, who is an MD and probably knows a lot more about peptides than any guru and like any crazy influencer that we hear in social media nowadays talking about peptides here and there, one for longevity that improves fat loss and gets you shredded or heals and makes you live for 100 years. So I want to understand better what peptides are and a lot of the science behind it and what makes it work, or is it actually something that we need to consider as evidence based? Is it effective? What do we know about it? There's a lot of confusion, and I want to make sure we make this a very informative and educational episode. So, any questions around peptides, this noise that is around, is clear up with someone who probably knows his shit. So, Kyle, welcome to the show. I want to introduce you first by just asking who is Kyle and why you do what you do.
Yeah, as you mentioned, I'm a medical doctor. I'm dual board certified in family medicine and obesity medicine. And I've always known that I wanted to do health optimization. And I want to practice what we consider evidence-based medicine. So I am a fan of pharmacology and mechanism of action. And peptides are no different than any other medication. Yes, there's some supplements that are peptides like creatine, but I want to understand basically what the molecule does to the body and how the body metabolizes the molecule. This is the same whether it's a peptide medication, peptide supplement, regular medication, or regular supplement, non-peptide supplement. So the way that I think about peptides is actually the exact same as I think about medications. And if you think about someone who knows a lot about medications, let's say they have a PharmD, a doctorate in, um, you know, uh, they're a pharmacist, and they may know a ton about medications, and a peptide guru might know a lot about the peptide. They might share my passion for pharmacology, but a clinician is going to be who is best served for prescribing medications. You generally do not want a pharmacist prescribing medications, even though they know a ton about them, and you do not want a guru, non-physician guru, prescribing your peptides. One, because they don't have a medical license and they can't prescribe them to a pharmacy. You would just be getting them off a research chemical website for which they would receive a commission. So that's how I see peptides, exactly the same as all other medications that I prescribe.
I love that you're saying that peptides are actually more common than we think they are. It's just probably now that the word, there's more noise around some specific peptides that are coming into the market in the fitness industry, or like in the wellness industry, spas and stuff like that, that where I just hear I am using these X, Y, or Z peptide that is awesome for longevity and makes you heal like faster fat loss, or makes you do this or that. So one thing that I am really curious about is how do peptides differ from traditional hormones, or hormone therapy like testosterone, growth hormone, thyroid treatments, when it comes to targeting the specific tissue, or whether they have like generalized effects on on your full body.
Yeah, it depends on the peptide. So, of course, there is topical peptide therapies like GHK copper or GHK-Cu peptide, and a lot of times you can get that over the counter. There's different, even you can get a shampoo that says peptide shampoo, and it has these different oligopeptides, which are just tiny little small ones that might have some sort of benefit in the skin. But when most people say peptide, they're thinking about peptides that are subcutaneously injected because it's a small molecule. They're not going to have very high oral bioavailability. So basically, they work a lot better if you inject them. And the difference between them and traditional medications like hormone replacement, steroid hormones, estrogens, testosterone, is actually very minimal. In fact, if you compare a growth hormone releasing peptide like Tesamorelin, which is FDA approved, has multiple indications, with human growth hormone, omnitrope, neurotropin. The benefit risk standpoint is actually very similar, but it is nice that it still depends on your own body to make the growth hormone rather than directly replacing it. So some peptides are very similar, but it's important that you understand what the mechanism is going to be.
One thing that I'm interested in hear more about is which categories of peptides actually show the most promise in research. You've spoken about peptides for fat loss, muscle gain, healing, and longevity, but are these categories evidence based? Is there research showing promising results using this?
It's a great question. Obviously, for things like insulin and GLP-1s, the P in GLP is peptide. Those are peptide medications. And then for melanocortin peptides like bremelanotide and setmelanotide, excellent evidence. There's multiple peptides in all of those categories that are FDA approved and have multiple indications and have copious amounts of human clinical trials. So for people who are anti-peptide, what they probably mean, and maybe I'm giving them too much credit, they probably mean they're against research chemical only peptides that have no human trials whatsoever. Although they usually say that BPC-157 has no human trials, and yet it does. And there's a lot of human trials on some peptides. However, to play the devil's advocate and give the other side of the argument, most clinics and influencers promote peptides that they can make money off of. That's just a fact. That's what they do.
Okay.
And the same thing for supplements. It's okay if people have I don't think it's unethical to have a coupon code for a supplement company. It helps pay the bills and feed the families, right? But the problem is whatever peptides these websites are making, or whatever peptides the compounding pharmacies are making, that is what they happen to carry. And many of those do not have any human trials still, but they say, well, it helps your mitochondria, so it must help. And based off of animal trials, then it's very promising. And I don't think that mitochondrial peptides are very promising outside of mitochondrial storage disease or significant deconditioning. And I also don't think that even things like telomerase peptides are promising as a general anti-aging serum for everyone. I think that there's going to be excellent specific use cases. For example, people with progeria are probably going to benefit from telomerase class peptides or even mitochondrial peptides. And people with maternally inherited mitochondrial storage diseases are going to benefit from them. Unfortunately, it's not really being studied in conventional medicine. So that's when I think that anecdotal data of people who have taken these in the real world does matter. And that is taken into consideration when the FDA is trying to place these peptides in either category 1, category 2, or category 3. Not to go
What is
into too much
that?
detail.
Sorry,
So
I don't have an idea what you said about category. So when you say
yeah,
category one, two, three, is that in terms of like effectiveness or safety or risk, or what is this category about?
it's just a determination of which peptides are allowed to be bulk compounded at bulk compounding pharmacies, which are allowed to be individually compounded at non-bulk compounding pharmacies, and which are basically not yet categorized or considered as a product. So
Okay.
it's probably not important for the average individual. I think what is important for the average individual is general types of peptides. So you have your supplement peptides, GHKCU topical, creatine, glutathione, and those are completely fine to purchase from reputable companies over the counter. Then you have your prescribed peptides, things that either are bioidentical molecules that are not FDA approved, but are being used clinically with enough human trials and data to make it reasonable. And then you have, of course, the FDA approved ones. So these should be prescribed, and then these are okay to get over the counter. And when people say peptides, honestly, most of the ones they think of are over here in the prescribed category. The problem is they don't know whether or not to trust the clinic. That's why when people sign up for a membership service with the clinic that I have, Gillett Health, I do not upcharge whatsoever for peptides. So whatever the pharmacy charges, I charge the exact same to the patient. And honestly, I'm the only clinic that I've ever heard of that has done that. So I understand why people don't trust it, because they go to a clinic and they say this peptide is going to be amazing, but the clinic is making a 400% margin by prescribing this. So is there some unconscious bias? There might be a little bit. And the other thing that I think is very important for people to take away is they need to ask the prescribing healthcare provider, or the guru, if the guru happens to be a doctor. Sure, you can call me a guru if you like, but they need to ask about the benefits and the downsides, because just like a medication, if the physician can't explain both the upside and the downside, then I don't think they're ready to prescribe that.
Okay. So would you say that these peptides can have negative side effects as much as if you were using steroids or any other particular medication?
Yeah, depending on the person, I think that peptides can have more side effects than anabolic steroids or
Oh,
other medications. Yep. Now, a lot of peptides are bioidentical or near bioidentical, and they are often better if dosed appropriately, but they can certainly lead to very concerning side effects, like cancer. Faster cancer growth would be one that many peptides have.
it's interesting to hear you say that because I would have assumed that steroids would have been worse for like in terms of side effects or like long-term chronic side effects. When you think about short-term and long-term side effects, would you say that like peptides would have more like an acute, immediate side effects or like same long-term side effects?
It really depends on the peptide. If you talk with both of the companies that make the two different FDA-approved melanocortin receptor agonist peptides, both of them say that melanoma is not a contraindication. However, if you read the clinical literature, there's several case reports of melanoma growing much faster than you would expect it to, and it does bind to, um, you know, uh, alpha melanocyte stimulating hormone receptors. So, even if they say it's not a contraindication, I do think that people on that peptide, and that's actually one of the safer peptides, I do think that it would likely grow someone's melanoma faster than it would grow otherwise.
Oh, okay. Now, I have a few popular peptides that I've been hearing a lot about that I have no clue what they are or what they mean. One of those you just mentioned before, which is BPC-157. What's that? Maybe I'm
Yeah.
ignorant, but what is
No,
it?
that's great. That's great. Yeah, BPC-157 is a compound similar to GPC-157, gastric protective compound, and it does have protective effects on the gut. There's, it's certainly being looked at for inflammatory bowel disease types like Crohn's disease, but it basically increases VEGF, which is a angiogenic signal. What that means in normal English is it helps grow blood vessels and it helps increase blood flow to the areas it works on. So, if someone has angiomas, like little cherry red spots on their skin, theoretically, BPC-157 can make those worse. And if someone has one of those in their brain, which can happen as well, then perhaps it makes the blood flow there even more than you want it to. So, depending on the people, I think that that can certainly have some downsides. In fact, the opposite of BPC-157 is Avastin, which is very commonly used for basically vascular overgrowth in the eye. Sometimes people have to have this vascular overgrowth lasered off. So I do think that it would likely make that worse. So specifically for patients that are diabetic or on very high doses of semaglutide, then that is a potential concern for making that retinopathy worse. Yeah, the easy way to think about BPC-157, it increases blood flow, and it likely helps heal in the same way that platelet-rich plasma does. When your body sends blood to an area naturally, it's just sending plasma with growth factors.
So, what is the most common use for that particular one, especially nowadays? That this seems to be very, very popular.
Yeah. I would assume the most common use is being part of this stack called the Wolverine stack. One of my most popular reels was the best peptide for muscle building, but peptides aren't actually that great in muscle building, especially not BPC. I consider it more of a healing peptide, but it's probably mostly used in this Wolverine stack where that people kind of take cookie cutter because they think it's going to make them impervious to all injuries. But in my opinion, it's best taken the same as we use PRP, which is platelet-rich plasma clinically, which is for areas that are not very well vascularized. We don't have very good blood flow to those areas, and we can inject some PRP or do some BPC-157 and improve that blood flow. So that makes a lot of sense. And anecdotally, with hundreds of people, I have seen it work very well.
It kind of brings a curiosity or like a question around, would that then be used for perhaps like improving cellulite or like stubborn body fat? Because some of these areas are stubborn because there's like poor blood flow to these areas, and so there's like lack of oxygen, and that's what makes it more stubborn for the cells to release and get that mitochondria working properly with the oxygen. Am I making this up, or is it making sense, or like I don't know, maybe
Yeah,
I'm just like thinking about the mechanism. Like if you're saying that improves that vascularity and improve that flow, maybe that is what some people are using it for, but I have no idea. I'm just
it would certainly help. A lot of people who have cellulite, especially with like tight fibrous bands, a lot of times it also goes along with something like lipedema or even androedema, which is just a beer belly in a guy. It's particularly hard to lose that area of body fat. And hormones play a huge role as well. For example, with lipedema, more androgenic regimens usually help. Hormonal contraceptives usually make it worse. Pregnancy, very high estrogen state, usually makes it worse. So, with increased blood flow, it does help decrease the amount of toxins and inflammation that's in that area that leads to more scarring. But it's hard to say if that's the rate limiting step for actually chopping up the fat molecules called lipolysis and taking it away. For example, hyperbaric oxygen, if that was kind of the rate limiting step, you would think hyperbaric treatment would be great for those stubborn body fat areas, but it doesn't appear to be as much of the case. However, growth hormone releasing peptides very well might help. Um, all GHRPs, including GLP-1s, have the potential to help burn the more stubborn body fat areas. But things like water retention in the tissue make a big difference. For example, if you give someone a SERM like tamoxifen, which is just basically blocking some estrogen receptors, activating some estrogen receptors, it will basically block the estrogen receptors in that very estrogen dependent body fat tissue in the hips and glutes and legs. And within 1 week, it can look like you've burned a lot of the body fat, but just because it's not retaining that amount of estrogenic water in the area. So that's why a lot of people take tamoxifen to temporarily change the aesthetics of that area or to decrease water retention.
are these things localized or injected, or like you're taking as a pill, or how do that makes gets to the actual targeted tissue?
Yeah. Generally, peptides are injected subcutaneously and they work throughout your entire system.
Okay. So they just get injected in the area, or like wherever it is, so intramuscular, and they just know where to go.
Yeah, you can generally inject a peptide anywhere subcutaneously or intramuscularly on your body that is safe, and it will go to where you need it. However, for some peptides, BPC-157, GHK copper peptide, TB500, and some others, I do think that there is a benefit to injecting it locally. It's hard to say if that's a 10% extra benefit, a 20% extra benefit, but it's not as big as you would think.
You mentioned TBC 500, and I have that in my list. What is that one?
Yeah, it's basically a fragment of a thymic peptide. So people have a thymus. The thymus in children is very large, and then usually in adulthood, the thymus goes away. And that might be one reason why children heal better is they make more of these peptides from the thymus. But there used to be one called thymosin beta 4, and then they kind of made this arbitrary cutoff of how many amino acids it could have. So now it's called thymosin beta 4 fragment. Um, and basically, this is a growth agonist peptide. So I do think that it has utility in things like certain tendon injuries or certain ligament injuries for healing, especially when stacked with BPC-157.
There's another one that I have in my list that is CJC 1295. What's that one?
Yeah, lots of letters and numbers, so it must work really well with no side effects, right?
Yeah, what is that one for?
Yeah, so this is a GHRH analog. Basically, it's just a couple amino acids different. It's almost bioidentical. It's very similar to growth hormone releasing hormone. So it's similar to the hormone that your hypothalamus in the brain releases that goes down to your pituitary, and it literally binds one of the receptors that makes your pituitary make more growth hormone. So it makes your own body make more growth hormone. There's actually 12 types of CJC 1295, with or without DAC. That just means drug affinity complex, and that just makes it last longer. So I'm generally a fan of the CJC 1295 without DAC, but I actually like Tesamorelin, Semorelin, and Hexarelin, those three, a little bit more than CJC. I'm not completely against CJC, but it almost has too long of a half-life to where I worry about fluid retention due to excess growth hormone, higher blood glucoses due to excess growth hormone, and even things like carpal tunnel due to excess growth hormone. CJC was well studied in humans, but I believe they stopped its phase 2 clinical trial. There was a cardiovascular death in the trial that was probably not related to it, but the excess fluid volume probably didn't help. Again, if they studied it again, it would probably be safe, but I just like things that have made it through all three phases of clinical trials and that have been clinically utilized, like a Sermorelin or a Tesamorelin, given they have the exact same mechanism of action.
And what is the main use for that one particular?
The main use for Tesamorelin is in general lipodystrophy, like muscle wasting diseases where you have a lot of visceral adipose inside your abdomen, and muscle wasting peripherally, for which it works really well for. So it could probably be repurposed for people who have lots of visceral adipose around the liver and inside the other areas of the abdomen. But the main use for growth hormone releasing peptides in general, in my opinion, should be growth hormone deficiency for people that can still produce growth hormone from their pituitary.
Okay, so if you did use that one, but your growth hormone releasing um, from your pituitary and like overall from your hypothalamus, your overall growth hormone production is normal, would this have a side effect on suppressing that production, that natural production, and have a negative effect long term in your natural production if you stop using this peptide, or how would that be the effect?
Excellent question. These growth hormone releasing peptides do not suppress your natural production at all. They usually increase it in a dose dependent manner. So when you stop it, you go back to normal and there's no withdrawal effect. So that's a huge advantage of growth hormone releasing peptides. That being said, for people who start omnitropin or neurotropin or these brand name HGH, true growth hormone replacement, your growth hormone also usually goes back to normal pretty quickly. But I do think that in some cases of borderline growth hormone deficiency, there can be merit to upregulating the factory of growth hormone in your pituitary, because I think there's a bit of a legacy effect. Even after you stop, I think your production's a bit better than it would be if you just did regular growth hormone for a bit of time. There's just no clinical evidence to support that, but it makes sense.
It kind of makes me wonder what makes it different from perhaps a steroid where it can actually suppress the production of your natural hormone production and actually affect it long term and pretty much like create an atrophy in that gland that is producing that steroid.
Yeah, it's a big advantage of peptides is that there's not this prolonged withdrawal and atrophy of the area of the pituitary or the gonad that makes the hormone.
Okay, that's interesting. All right. So for fat loss and body recomposition, how do GLP-1 agonists like semaglutide fit into this peptide picture? And how do they compare to like growth hormones secretagogues like
Mm.
ipamorelin? I don't know
Yeah,
what that is.
a great question. So, ipamorelin is very similar to ghrelin. So,
Okay.
ghrelin's hungry hormone, but it also increases growth hormone. So you chop up fat more, and you often do have loss of fat from areas where you normally don't, which can be good if it's difficult body fat in cellulite or abdominal body fat. But it can be undesirable if it is body fat in the face. That's why they call it Ozempic face or semaglutide face or Ozempic, which was my term. But all GLP-1s increase growth hormone. So with both of these classes of peptides, increased growth hormone that's causing fat to turn over more is both a benefit and a detriment of that. However, of course, with GLP-1s, you also have four other mechanisms that's going to decrease appetite instead of increase appetite. It's also going to slow gut transit, so your intestines and gut are not going to push things forward as quickly. And it's also going to make changes in the liver to where it affects something called gluconeogenesis, which is basically your ability to make new glucose molecules. So generally, all those things are benefits for people in fat loss phases. The stronger the GLP-1, the more growth hormone you get, and the more potential you get for things like carpal tunnel or even eye issues. So dose is very important with GLP-1s.
With this GLP-1 thing, I wonder whether beyond just affecting appetite and reduce that food noise for a lot of people that struggle with a very huge appetite or like increased hunger, or that they have a struggle in the past just trying to follow a calorie deficit and they just don't seem to follow through for that long. You mentioned that it also has an effect on increasing growth hormone, which somehow increases the use of body fat stores as fuel. So, are you saying that, or is it probably the assumption that I'm making is being utilized like as a fat burner kind of thing?
Yeah, obviously it's not breaking the laws of thermodynamics, but you're certainly burning fat in areas that you wouldn't be if you were in the same caloric deficit and not on a GLP-1.
Okay.
So sometimes there's kind of a certain look to it, as there is for almost all compounds. With enough years of training, you can look at people and generally tell if they've been on a high dose of whatever they have been on or how likely it is. But the caveat is you have to be careful if someone's just generally lean. You're looking for proportions of leanness. For example, how much fat wasting does someone have in their face versus the rest of their body? Because, if someone's just very lean in general, they're probably going to be relatively lean in the face as well, but they're not going to be extremely lean in the face. It's kind of like a whole new version of natty or not. People used to do it for steroids, and now people do it for peptides.
Quick question about that. So, would someone who uses peptides, are they still considered natty in the bodybuilding world? Maybe this is a question you may not know, or maybe you do. But I'm somehow interested in understanding what that means.
Yeah, it depends on what bodybuilder you talk to. A lot of bodybuilders say they're completely natural, but they're on, HRT or TRT. I would argue, even things like hormonal contraceptives is just synthetic HRT and is not natural. Depending on what synthetic HRT you're on, if you're on drospirenone, that might be performance worsening, whereas if you're on levonorgestrel, it might be performance enhancing. And people don't even think about that. So, my definition of natural or not is, um, you know, almost any medication or peptide makes you not technically natural. But I think a lot of people just want to know, has this person done a huge cycle of, you know, synthetic steroids or not? So I would
Yeah.
say if that's your definition, then yeah, medications and peptides are very reasonable. And, it's, if anything, it's just semantics that people like to play the game.
I want to know your stance or what is all about this clenbuterol. Is this something that it is a peptide, or is it a different thing? And what do you think about the use of that for a lot of people that have been using this to increase their stubborn body fat loss? Especially, I see this in a lot of bodybuilding world, and I hear a lot. And I think there's like a lot of controversy, or like, it's a little bit of like in the black market, or like it's a bit shady. So why is that?
Yeah, it's a good question. So clenbuterol is a beta agonist. So people are familiar with beta blockers. They help remodel the heart. Clenbuterol is the opposite. It activates those beta receptors, and it's a fairly non-selective beta agonist. People are also familiar with albuterol, even the albuterol inhaler. That's why something like 50% of Olympians are asthmatic with therapeutic use exemptions. And many soccer players, especially in areas that are cold or rainy, like England, are quote unquote asthmatic. So they get therapeutic use exemptions. Albuterol and clenbuterol are absolutely performance enhancing, not just from a body composition standpoint. Of course, for females, I wouldn't say they're more powerful in females, but relatively they're more powerful because females are not going to have near as high as testosterone, even if they're natural, or sorry, even if they're on testosterone replacement or HRT. So clenbuterol can feel much stronger from a body recomp standpoint. However, generally oral clenbuterol, which is the only version I've ever seen, clenbuterol is very long acting. Um, the downsides are generally not worth the upsides. So that's why in the United States, it's not even prescribed anymore. I think there's a few countries where it's used clinically, but generally in the United States, we just use albuterol. And usually we start with inhaled albuterol because it causes less tachycardia. A worst case scenario is if someone combines a beta agonist with alcohol and, they get sick and they have an AFib episode. So it probably would increase the risk of something like that. Or even negative cardiac remodeling, which is just where the heart thickens because it's beating faster and harder. But that being said, I do think that it's kind of a bummer that we don't have more beta agonists available for people that do get exercise-induced bronchospasm or exercise-induced asthma. I think that, kind of the more atopic someone is, which is allergies, asthma, and eczema, um, the more aggressively they should think about some sort of, even if it's like an as needed albuterol inhaler before they train, that can give them a pretty good benefit, especially if they're tired and their cardio is not going to be good otherwise. It can be a game changer.
If someone is quote unquote healthy, has no asthma or allergies whatsoever, what is the risk and what are the effects of clenbuterol or albuterol on your health? Like, do you actually get to have a higher risk if you use it short term versus you use it like I don't know, like one off, or like,
Yeah.
or like whether you use it for a longer period of time?
Mhm. Yeah. And, I think you could say that this is a good theoretical question for any sort of substance. With clenbuterol specifically, there's a dose-dependent side effect risk of tremor and insomnia. It can be very difficult to sleep while on clenbuterol. That's one good thing about albuterol and other beta agonists is fast in, fast out, whereas clenbuterol is pretty slow. And a lot of people have, more tachycardic episodes. So, I'd think about non-fatal tachyarrhythmias, which is basically abnormal heartbeats where it's fast that lead to symptoms and also worse electrical health of your heart. It's just difficult to say if that'd be a long-term side effect or not. Probably not in someone particularly young and healthy, um, but it's something that they'd have to be counseled on if clenbuterol is still prescribed. The long-term side effect being more if you took it, for years rather than 2 weeks. In 2 weeks, there's not going to be any risk for negative cardiac remodeling. So, if you took it for 20 years, I think it'd be pretty likely. In fact, one individual told me at one point, he said, "Hey, my friend has figured out the perfect formula. It's safe, it's pretty natural, and you can be strong, jacked, and lean all year round. You just have to take Clenbuterol and something like 300 mgs of testosterone cypionate per week, and there's no downsides." And
Okay.
maybe they cycled Clenbuterol off and on, 3 weeks on, 1 week off. Um, and I think that in that case, if someone planned to do it for years, that my main concern with that would just be the negative cardiac remodeling and the tachyarrhythmias. Perhaps there's a low enough dose. Clenbuterol is very strong. When it was used clinically, I believe it was in micrograms, like very low amounts of micrograms. Um, but it's hard to say how big its therapeutic window is. So people might not be familiar with a therapeutic window. Think about it, you're on a cliff, and on one side of the cliff, there's no effect of the medication. On the other side of the cliff, you have lots of side effects. And a wide therapeutic window is like this. You can take a bunch of different doses of medication, and you're in the good zone. But with clenbuterol, I think that's a pretty narrow therapeutic window. And as you age, it narrows more and more and more.
Okay. Let's talk safety. So, what risks, side effects, or contradictions do you monitor closely when you prescribe peptides in
Yeah.
overall, generally?
Yep. For the general peptide, I'd say the number one thing is just cancer detection and prevention. So there's cancer screenings, there's early cancer detection tests, there's imaging tests, preventive imaging tests, there's genetic tests. And generally, I like to do most of these, especially in someone who is in more advanced age, just because they're more at risk of having a tumor. Because a lot of peptides theoretically would grow tumors. So, especially if they take them for a long period of time. Now, if you have someone who's relatively young, say they're in their 30s, and they have no family history and they're healthy otherwise, then I don't do all those different tests if it's a short 6-week course of some healing peptides. But it's a conversation that I do have with each patient. The next thing would be glucose levels. So, especially for I very commonly give people a continuous glucose monitor that they put on, like a Freestyle Libre or a Stello or a Dexcom. And the third thing would just be skin changes. So, if they're going to start bremelanotide, which is PT141, counsel them that their skin may get a tiny bit darker. And if they use a ton of it, perhaps even they would like lose some photo bleaching effect of their hair. And then conversely, if they have vascular lesions, then it's potential that those could get worse, but those are just mostly cosmetic and they can be very easily zapped with a laser. But it is a conversation that I have with patients.
Okay. How should someone get their blood work monitored while using peptides? And what probably would you say are red flags that you should be looking at in your labs?
Yeah. Fortunately, there's not a ton of different tests from what I'd recommend generally. And I posted my favorite lab panels on both sagebio.com and gillettehealth.com. And people would usually just get a comprehensive panel or an advanced panel or an athlete panel, depending on the situation. But I guess the important takeaway with, what you're getting is just knowing what to look for. So if you're on CJC 1295, then you definitely want to get an IGF-1 level, because that's the marker of basically how much growth hormone that peptide is producing. And you probably don't want to go over about 300. It's no different than if you were on hormone replacement or testosterone replacement and you wanted to check your estrogen and testosterone.
For people that are using nowadays peptides without medical oversight, what are the biggest mistakes or dangers that you may find right now?
Yeah, kind of the same dangers as people who are self-prescribing TRT. So there's, females are usually better at this than males, but there's certainly a lot of males that have kind of quote unquote prescribed themselves their testosterone replacement. They've gotten it not prescribed by a doctor for even decades, I've seen. And a lot of those people say, oh, well, I've taken testosterone from my friend I met here for 20 years and I've never had any side effects. And then you check their heart scan and they have some um, cardiac hypertrophy, or they have some cardiac plaque, or you check their heart rate and they're an AFib from time to time, so they have some electrical disease. So these hidden side effects are really the main concerns. And I have seen patients before come in with actively, aggressively growing cancers that have been taking huge amounts of peptides. Fortunately, it doesn't happen often, but I have seen those cases. And I've also seen people that have taken a bunch of peptides and given themselves prediabetes, borderlining on diabetes, because their glucose levels are running so high. So it's kind of the same side effects we look at clinically, but people are feeling great. Maybe they get their labs done and they just don't get enough. They have a glucose that looks normal, but their A1C and insulin are elevated.
You mentioned something that just brought up a question that may have not to relation with a specific peptides, but I see and hear a lot of people using and out of prescribing metformin just to manage their glucose management, or just I don't know. I've heard that there is the intention of improving the insulin sensitivity, even if they are actually already insulin sensitive. But the more insulin sensitivity, the better. What is your stance on using metformin without really needing it, or like without being a diabetic or insulin resistant?
Yeah, I'm generally against that, just because there's better options. Maybe 15 or 20 years ago, it would have been reasonable, but metformin does blunt IGF-1 signaling, which can help with muscle growth. It's really most concerning. If you were a bodybuilder, then you would very likely not want to take metformin. Not because it's very strong at blocking muscle building, but because it does slow muscle growth. And also, it can lead to what I call a reshuffling of the gut microbiome. So, if your gut microbiome is really healthy, then it might get worse on metformin. If your gut microbiome is very unhealthy, then it's very likely to get better, just because metformin is going to make you metabolically healthy. So, not a huge fan for people who aren't diabetic or pre-diabetic. Better options would be things like allulose, which is a technically natural non-nutritive sweetener, or things like miglitol if they're looking for a prescription, which is an alpha-glucosidase inhibitor. It basically affects how you absorb carbs. Or even things like SGLT2 inhibitors, which is where you kind of pee out some electrolytes and glucose. Or if it's pretty mild, but you're worried about insulin resistance, even something like inositol is reasonable.
Berberine, is it in kind of like the same effect as inositol, or because I've heard a lot about berberine, and which is really really helpful and seems to be even stronger and helpful for fat loss, especially in women with PCOS and issues with the estrogen dominance and things like that. So, where do you stand with berberine use?
Yeah, I think it's also great for cases of SIBO, especially if people are constipated from time to time, not because it's a laxative, but because it's an antimicrobial. It's a good natural antimicrobial, along with things like emulsified oregano oil, which is ADP. But the main concern with berberine is, do you really want it to be working in your bloodstream? For example, are your glucoses actually high? Or do you want it to have an insulin sensitization benefit on your gut and a beneficial effect on the gut microbiome? Things like berberine or even quercetin or even curcumin, you might not want to be bioavailable. So you might want those to stay in the gut and not be absorbed in your system. Because if you take a high dose of bioavailable berberine right before you go to bed, then you can be hypoglycemic at night and you might not sleep well. So there's certainly risks, but in general, I do like berberine quite a bit. And my favorite berberine for the average person is just, a low dose, maybe 100 to 250 mgs, without any sort of bioavailable upregulator. So no black pepper fruit extract, nothing else with it. And with the first meal of the day.
What about people that are taking it with every single meal?
I suppose if they're not getting dawn phenomenon and they're checking their glucoses, maybe they're wearing a continuous glucose monitor at night, or if they just have very high glucoses, then I think it's reasonable to take with every meal. But I could probably make a case that unless you can't tolerate it, most people with significant insulin resistance, certainly most diabetics, should be on berberine with each meal.
Okay, interesting. Where is the research most exciting right now when it comes to peptide development or anything in the pipeline when you think about the shift in the industry using more peptides nowadays than before?
Yeah. One of the most exciting peptide developments is the different amylin analogs that are going to come out. Pramlintide is a very short acting one that has been around a while. And basically, amylin is a peptide that our body makes. It comes from the beta cell of the pancreas, just like insulin. So when you lose beta cell function and you lose some insulin, you also lose amylin too, but we generally don't replace it like we do insulin. But it has many benefits outside of weight loss. It's a great insulin sensitizer, and it's a non GLP-1. So it helps balance out a lot of the negatives. And I think it's just going to decrease the amount of the strength of dose of those that we need to use. So I'm very excited for that. It's also a great option for type 1 diabetics that don't have as many options as some people. And then the melanocortin receptor agonists are, of course, very exciting as well. Those are your setmelanotide, which is fantastic for hyperphagia. And it's even stronger than the GLP-1s when it comes to kind of turning off that food signal. So I'm very interested to see if that is being able to be prescribed more and more. I believe Invicri is the brand name, but it's usually just prescribed in kids with genetic hyperphagia. And then finally is, I guess these aren't technically peptides, but the most exciting probably of all is the myostatin inhibitors. So there's several different types or classes of these. Lots of them, they have a mechanism of action that ends up decreasing or inhibiting myostatin. So basically, it turns off the signal that our body sends to stop growing muscle. So the clinical trials of these, which are usually done via IV infusion up till now, people lose a whole bunch of fat and gain a whole bunch of muscle at the same time compared to placebo. So these myostatin inhibitors like bimagrumab, I think are going to be huge. The next big GLP-1 type therapy. It's just that most of these are not technically a peptide, but people call them peptides.
I'm interested in hearing your thoughts on the future with the accessibility. One is prescription and accessibility to these compounds and peptides. And two is price wise, because they are very expensive. And on top of that, you have to have a pile of labs and things like that on an ongoing basis to make sure that you're using it the right way and there's no like chronic side effects. But on your end, what do you think this resolving or turning into, mostly with that two things, availability and price wise?
Yeah. So this is a great question. A lot of the price is related to how they have to be administered. So again, most peptides are injected subcutaneously because they're not absorbed well if you take a pill. Now, there's exceptions to that, and there's ways that you can make it otherwise to where it's kind of absorbed in your mouth, and there's liposomal formulations of some things, but it can be expensive to make. The insulin peptide was found many years ago, and insulin is still expensive to this day. And yes, there's been programs that have made it slightly more affordable, but unless there's a huge breakthrough in technology that makes it very cheap to make solid liposomal tablets, I know Jim Lavelle has studied this quite a bit. He's a pharmacist. So perhaps there will be some sort of breakthrough that will help. But um, for now, yeah, peptides remain relatively expensive. That being said, um, I think that the wholesale prices at compounding pharmacies are pretty good. So patients often come to our clinic and they pay our membership fee, which is significantly more expensive than their previous clinic, but then they pay 1/8 the price that they were previously paying for their peptide because the last clinic was just multiplying the price by 8, $100 to $800, and they ended up saving a lot of money. So again, I speak very candidly on these podcasts just because I sleep well at night. Doing so, that's kind of just how I feel. And, a lot of the peptide clinics don't love that I say that, but I just want to be as straightforward as possible, saying, yes, they can be expensive. A lot of peptides for a vial run between about $100 and $200. Some, like L-carnitine, even sterile L-carnitine, are very cheap, only $15 to $30 per vial. But yeah, certainly compared to tablets, until we can get peptides to be absorbed well in tablet form, they are going to be significantly more expensive than tablets or capsules.
Where do you stand with L-carnitine tablets versus like the effects when you inject? Because this is something that I also hear a lot in the bodybuilding industry. They are using these a lot and like very locally. What is your stance on the effects or the use of L-carnitine, and what makes it more effective injecting versus like using this fat burner that has L-carnitine?
Yeah, it's a great question. So, even something like a decade ago, Alex, or the prep coach, wrote that little ebook on injectable L-carnitine. And, probably also something like a decade ago, my friend Derek with More Plates, More Dates is talking about how L-carnitine has much better, use, because when you inject it, it's going to act throughout the whole body. Whereas if you take the supplements, its bioavailability is not super high. That being said, depending on the person, it might have 5% bioavailability, 30% bioavailability. Perhaps taking it with a meal helps its bioavailability to some degree. When I take oral L-carnitine myself, then a lot of times I take between 750 and 1500 mgs each meal of the day, because I think that's going to be better than taking 4500 mgs with one meal of the day. So I do think that, drop it in nice and easy. Don't take it all at one time. You're more likely to get gut disruption when that happens too, and potential TMAO conversion, which is a potential carcinogen. One study that I would like to some people exercise caution is a study in uncontrolled diabetics that have plaque progression when given L-carnitine compared to placebo. So L-carnitine is probably not perfect, but it is just 2 amino acids, and it is pretty fantastic from an energy shunting standpoint.
Okay. That's very, very interesting. And I think one part that I want to kind of like close up, because I am aware of the time, but we kind of like were a little bit longer than expected, is just to do a bit of overrated, underrated. This is like my favorite part. And I will kind of like brief you on a statement. You will let me know whether you think it is overrated or underrated. Number one, this is around clinical use and biohacking. So, MK677, ibutamoren, overrated or underrated?
For clinical use in biohacking, underrated.
What is that for?
I think it's underrated for pediatric growth hormone deficiency. And I think it's also underrated for adult growth hormone deficiency. For bodybuilding and muscle building, I think it's somewhat overrated. And it is absolutely notorious, kind of the worst for elevating blood glucoses.
Okay. Number two, GLP-1 agonist like semaglutide and tirzepatide, over or underrated?
Yeah. For clinical use, I would probably have to say these are overrated because people just keep increasing the doses and don't incorporate the lifestyle things. Most people get these at their med spa, but they are my favorite medications. They're just absolutely ubiquitous.
Okay. BPC-157 oral versus injectable.
I would say both oral and injectable for general clinic use. I would say underrated. There's some clinics that want to prescribe these to everyone, but they're not used near enough clinically. There's still not that many physicians that are prescribing this. Perhaps for biohacking, it's overrated.
Okay. GHRP versus GH-based peptides.
Yeah. So GHRPs, but there's kind of like there's actually three categories of GHRPs. GLP-1s are technically one, but GHRH analogs like CJC, Semorelin, I would say underrated, but also people don't take into account side effects. And ghrelin agonists like ibutamoren, MK677, or ipamorelin. I think we've also already mentioned that those are to some degree underrated, especially for people who are trying to gain weight.
Okay. IGF-1, LR3 for hypertrophy.
Yeah, underrated. So this is IGF-1 with an arginine. I think it's third amino acids replaced with arginine. Has a much longer half-life than regular IGF-1, which is FDA-approved and clinically used for certain conditions.
Kispeptin for fertility, or HPTA for restoration.
Underrated for HPTA restoration in the case of hypothalamic amenorrhea for males wanting HPTA restoration. Overrated.
Okay. What is HPTA?
Hypothalamic pituitary. A technically stands for adrenal, T stands for thyroid, but it's just thought of as your brain and endocrine organ axis. So HPG would be hypothalamic pituitary gonadal. But basically, if someone's been taking a steroid, or if someone's had high prolactin, or for whatever reason they've been taking, synthetic steroids, hormonal contraceptives, and they want to wake up their pituitary, then it can be used for that.
Okay. Using peptides in place of TRT.
Overrated.
Yeah. Thymosin alpha 1 for immunity.
Overrated.
Okay. CJC 1295 plus ipamorelin stacks.
So that is very strong, but I'll say overrated just because I have other preferred options like Tesamorelin, Hexarelin, and Semorelin.
Okay. What is it all about these stacks that nowadays are coming? Like, you're not using just one single peptide, but it's kind of like you're doing a kind of a combination. What is this about?
Yeah. Theoretically, you get more benefit with less downside. So classically, BPC with either injectable GHK or tripeptide, some people call it, or a thymic peptide like TB4 frag or TB500. So there's some benefit to that where you can probably use less and still get even more benefit. And the same thing with CJC and ipamorelin. Both of those bind a different receptor on the pituitary. So you can often use 1/4 the dose of both, but get the same growth hormone output. The key is to just modulate the dose down to where your IGF-1 is not too high.
Okay. Now, peptides for female hormone balance and PCOS.
Overrated.
Overrated. One question that I had from Instagram, which was in that question box, is what are some of the best peptides for athletes looking help for endurance and strength?
If it's specifically an athlete with PCOS or some sort of amenorrhea, possibly a very low dose of a GLP-1, sometimes even under the normal starting dose. Past that, I think a lot of athletes don't think about nutrient absorption or iron status as much. So, there's certainly if they have gut inflammation, there's certainly some of the growth agonist peptides or even growth hormone releasing peptides that could be of some benefit. But, there's a lot of peptides that are, I think, phenomenal for athletes looking for this benefit that can help things like treat anemia with, the female athlete triad, anemia or borderline anemia, extremely common in athletes, unfortunately, especially if they run or jump often. The foot striking leads to that increased risk too. And one of my favorite up-and-coming peptides is ARA290, an erythropoietin-derived peptide, if people know what EPO is. But this peptide has fantastic clinical evidence in human trials of many types, but it's difficult to make. So no pharmacies make it, unfortunately. And I can't even, I don't even think that the research chemical websites have it. So ARA290 would be my favorite peptide in athletes like you mentioned that say have anemia, perhaps, but it's just not available.
Restoring hypothalamic amenorrhea, is it something that you think you're more prone to do it with a protocol of nutrition, restoration, recovery, uh, good time off from like a lot of volume and intensity? Or you reckon that there is like a magic option with these new peptides?
Yeah, I do have a stack. I won't share all of it, but it does include some sort of estrogen, and it does include a couple different peptides. It also includes now low-dose naltrexone, and it also includes specific dietary changes. I actually put those individuals on a high fructose diet, high fructose, like lots of blueberries, for example, and I have them avoid allulose, and I actually have them avoid canola oil. It's one of the only situations where I have them avoid that specific oil. Actually, I am not anti-seed oil, but in the cases of then I have them do that. And there's a couple other things that we employ, but we've had great success in our practice with patients on the HA spectrum because it's not you have it or you don't. A lot of people come in wondering if they have it. Um, it's a continuum.
Okay. May I ask why the fructose and why the elimination of canola oil?
Yeah. It seems to be that benefit partly to do with leptin. So leptin is an adipose brain axis hormone. Think of turning your hypothalamus on, kind of like turning on like the codes to a nuclear weapon. You need to turn on 4 or 5 keys. You can't just turn on leptin. Studies on leptin don't look great, but you generally want a slightly higher triglyceride level. And you're inducing this kind of not artificial, this actual state of metabolically higher, more active fat cells. You don't actually need more fat cells. You just need them to be more active, producing endocrine hormones like leptin. And fructose and allulose bind to very specific receptors. For a lot of the reasons why the rodents that Dr. Johnson studies, I think he's at University of Colorado, for the same reason that they get very obese um, when they're fed high fructose diets. High fructose levels also help kind of turn on that one switch, but you have to turn on the estrogen switch at the same time. You have to turn on the kisspeptin switch at the same time. So there's a lot of these switches, and you have to turn off certain switches that have to do with opioid receptors.
That's interesting. I think we could just speak about all of these mechanisms for hours and hours. I am very grateful for all the information and all the time you have spent with me today. This is a very complex topic, and even like for me as a second language speaker, when I hear you saying all these combination of numbers and words, it's like, what the fuck is that? But I think this is becoming so much more popular and it's coming out more and more that I think it is important for just get a better understanding on this topic. Now, when someone wants to use or is thinking about whether a peptide would be an option for them, what is your recommendation? Where do you even start?
Yeah, I would start the same place as if they're curious about medication, is just ask their healthcare provider, or if they're at a clinic that has health coaches or care coordinators that can forward on the message. Um, ask like any other one, and I would also look up to see is this made by reputable supplement companies? Does Designs for Health or whatever else, I'm not sponsored by any supplement company, but, if it's carnitine, does Gorilla Mind make it, for example? But so yeah, look it up, make sure it's not one that's possibly available over the counter. There are some formulations of glutathione, for example, that are available over the counter.
Okay.
But yeah, for anything that's like sterile or injectable, I would just reach out to their healthcare provider. And people say, well, my doctor doesn't know anything about peptides, or they probably do know about some peptides like insulin, but they just don't understand what a peptide is. I would say, well, if you were going to like go into making widgets, you would probably get a lawyer that understands making widgets. Same thing for medicine. If you have a car and your mechanic does not know how to take care of your car, then find a new mechanic. So for those people, I would find a new healthcare provider, and I think they would be surprised that the cost of one is quite affordable, especially if they go with a newer one.
That's awesome. Well, Kyle, thank you so much for your time, for your gracious way to explain things, and I am looking forward to editing this video and putting it out there. It's going to be awesome for a lot of people that are just looking forward to hearing about this episode. So thank you again. Where can people find you? Is there any projects coming for you?
Yeah. We've been trying to do more of the Just the Basics series for our Gillett Health podcast. So you don't have to have PhD to listen to the Gillett Health podcast on all platforms. Of course, they can find me on Instagram, Kyle Gillett MD, sagebio.com, or gilletthealth.com.
Awesome. Well, I was very excited to talk to you. Thank you so much again for coming up, and I'll talk to you very soon.
My pleasure.